and welcome to another edition of Patcast. Today is February 27th, 2024, and it's a Tuesday. I'm Rifat Manan in California. So today we are very delighted to welcome back Dr. Lester Thompson, who needs no introduction to people in pathology and especially head and neck pathology. Today he is going to give a talk on WHO update on thyroid pathology. And thank you, Dr. Thompson, for joining us today. And for those who are joining online, and they can feel free to post your questions or comments on Facebook and YouTube chat windows. And I would pass on to Dr. Thompson at the end of the talk. And over to you now, Dr. Thompson. Thank you again.
Thank you very much. It's a pleasure to be here again. And of course, it is sunny California this morning, although it was pouring with rain yesterday. So I'm glad that we have sunshiny weather today. So I am going to turn off my video just so you can actually see the presentation itself. And I'm going to try and give you an update on what has happened with the new WHO for thyroid. And specifically in this case, we always think about it's important to kind of know the names of things, because if you don't know the name of the thing, you're never going to be able to follow it. And this was one of the original lines from Carl Linnaeus, the person who came up with the first sort of taxonomy in biology, and it has been updated ever since the mid-1700s. And so for us, the whole reason we're doing this is if you give correct names to cancers and so forth, you're really in a mission to be able to defeat them. So just, overarching, the World Health Organization started in 1956 with the responsibility of classifying these lesions, with the Blue Books providing an evidence-based classification for all tumor types so that they can be used in a global basis. And of course, this allows patients to receive, the most appropriate treatment, as well as having everyone who does research in the topic actually researching the same thing. So in a way, the Blue Books are definitely not just for pathologists, even though pathologists are quite heavily involved in the writing of these particular books. So in summary, kind of just what is different about the entire 5th edition of the WHO books, and that is an entirely different governance was established, a difference in the level of quality and standards was used, and then, of course, a change in how the volumes were being produced. So I do think that having both a standing editorial board that has expert members from each of the major disciplines on it, and then also incorporating people with expert knowledge as the additional editors for that edition, means that you really are able to get the best overall group, and therefore a major increase in the number of participants. I'll get to that here in a few moments, but you can see more than 2,500 authors have been involved in the 5th edition. I do think that some of the major standouts for this is that it links to other organizations. So in this instance, the coding, AJCC staging, the international collaboration on cancer reporting, genetics and their implementation have all been linked back into this on a formal basis. So it is actually included legitimately. And then, of course, trying to get standardization for neuroendocrine lesions, hematolymphoid and soft tissue. Trying to standardize even something as simple as, calculating mitoses and going to mitoses per 2 square millimeters, especially now that we have digital imaging available to us, allows people to have a much more easily referenced standard for this. And then, of course, having all of the production side, I'll have the website where all of the references and digital whole slides and notes can be interactive. This allows you as the user to be able to look at it. So when you think about the 2003 edition, at that particular point, it was this very, standardized 6-block cover for it. And, I was involved at that particular time, so I really have been involved with these books for more than 20 years now. So I have aged over this time frame. That was the next book that we put out in 2017. And then, of course, now the new book, of course, had to have the meetings via Zoom in order to be able to incorporate what we were doing and how we were saying it. And so this was the classic look every single day when we were doing our evaluations for the editorial board. 29 editors for the book. So, when you talk about having a wealth of expertise available to you. This is clearly what we had. As you notice, there were only 5 editors for the 4th edition. So, basically an exponential increase. But that does mean that each of the people involved had a very specific interest or a specific focus for what they were able to provide. And therefore, you're getting top-notch quality for each of these areas. You'll notice there are 5 names that are highlighted in yellow. The reason behind that is we were the members of the standing editorial board. So this meant that the 5 of us served on the board for a 5 or 6 year period from the beginning until the end, in order to mean that there was a harmonization of terminology and classification throughout. So when we were talking about paraganglioma lesions, as an example, in the GI tract book, we were, as the people from the standing editorial board, able to say, wait, let's use this particular terminology because we know we're going to have that in the endocrine book later on in the series. So this means that definitions, epidemiological data, etiology, and so forth is very well standardized throughout the book. So you have the same references and the same nomenclature throughout, which I think is a major change. So 128 unique entities in this book, and now in a hierarchical organization. So in other words, in the previous editions, you had the malignant lesions first, and then you had the benign and the uncertain malignant potential. So now we started off with hamartoma or tumor-like lesions, then going to benign tumors, then those of uncertain or borderline nature, and then the malignant tumors. If they were the most common and the highest frequency, where you're talking about, 90% of the tumors fit into a certain category, they would be listed first. But in general, trying to go from a low to a high grade classification scheme for that hierarchical evidence. Another one of the major changes is to try and aggregate all of the tumor entities into specific anatomic sites to avoid redundancy. So in other words, soft tissue-related lesions can occur in every one of the endocrine organs, but rather than repeating 10 different entities in each anatomic site, the chapter was separated out and recognized that the lesions develop in each of these anatomic sites at a certain percent. So I do think that along with the hematolymphoid, germ cell, mets, and so forth, allowed for a much greater organization of the book, and therefore a reduction in the number of pages. I know it doesn't seem like it when you read the book, but there really is a overall reduction. So I'm actually going to drive the online version here for a moment. If you go to tumorclassifications.iarc.who.int, you would be able to see it. You can actually look at the previous 4th edition books and then go through the 5th edition, and you'll see that all of the books are up there in a electronic format that allows you to be able to review them quite easily. So if you go into the neuroendocrine and endocrine tumor book, you can see that all of the various chapters are outlined as you go through, with pancreas and neuroendocrine lesions in non-endocrine organs, all the way down to the genetic tumor syndromes. And I'm going to just kind of talk about the thyroid here for a moment, but since that's the topic we're going to do, you can see that here are all of the various things, starting off with developmental and then going to follicular cell-derived lesions with an increasing evidence of malignancy, C-cell, mixed C-cell, salivary gland, thyroid of uncertain potential, thymic lesions, and finally ending with embryonal tumors. So if you go into one of the chapters, and I'm just choosing thyroblastoma to highlight some of the features, you will notice that along the left are all of the various sections that are included in every chapter. You can click on one and it takes you immediately to that particular space in the book where you can see who the editors and authors are on the side. And then, of course, as you look at them, you can highlight things yourself. So you can add to your favorites. You can actually put in comments and notes to yourself as you look at it as a person who's logged into it. So the definition and related terminology is used throughout with various subtypes incorporated. Of course, for thyroid, localization is kind of thyroid, but the clinical features are then also discussed in some detail, going on to epidemiological data that includes sex and where they age develop. The etiology is included when it is known, and if it is not really known, then it is also spoken about in the pathogenesis section, followed by the microscopic and histologic features, with the histology also including immunohistochemistry and, importantly, a differential. So here we were able to incorporate some of the things that may be considered. Cytology is absolute for thyroid, and so that was included along with any diagnostic molecular pathology. And then a new section for this book is the essential and desirable diagnostic criteria. This allows for specific features that needs to be present to make the diagnosis, and then finally staging and prognosis. Now, one of the things that I do think when you look at this, you'll notice all of these little squiggly brackets throughout. And those little squiggly brackets are each going to the actual references, and that is the PubMed ID for that particular topic. So here, as an example, I'll just click on one of them and show you. You can link through directly into PubMed, and here you're able to see the reference. Depending on what your access would be, you would actually be able to go and download that particular article. So the source material that was available for that particular citation is immediately available to you as well, so that you're able to detect it. Let's talk about the images for a few moments. Yeah, you can actually go and look at the original image that was uploaded. You can actually download this. You can just do a right click and download. So you can use those exact same images. They, of course, incorporate things like the immunohistochemical findings, as you can see here. And also, importantly, again, cytology-related features. We did feel for thyroid, especially, cytology needed to be included for every one of them. And then, my particular favorite is, of course, the idea of a virtual whole slide. So here I'm going to just drive for a couple seconds the actual virtual slide that was loaded of a thyroblastoma. So here, as a individual who may not be familiar with the diagnosis, you're going to be able to drive a vetted case where someone who is an expert in the field has actually selected this particular tumor, and you can go all the way up to 40x. You can actually do screenshot captures. You can do whatever you like with these images. And so it's kind of an idea of having a gold standard that allows you to be able to focus on this particular topic. So I do feel that this new book has several fantastic features, with the whole slide imaging being one of them. The notion that every single reference is linked to a PubMed ID, which means that you are able to also go and look at those particular references and look at the source material yourself, rather than just necessarily trusting what has happened. And then, because it is an online version, it allows you to look at many more images than what are actually in the printed book. So, the binding of a printed book is somewhere around 550 to 600 pages. And if it's much more than that, then, the binding will break. So in this particular case, you can put in a lot more images. And as the editors went through these sections, we would say, this is a fantastic picture for the book. And then you're like, oh, but this one is equally as good. Well, rather than duplicate it, let's just put it on the online version. So truly, that particular feature is a fantastic one to do. Okay, so let's start off with some of the lesions. And you may say developmental abnormalities. How are those tumors or cancer, since you're talking about a WHO tumor book? Well, these present as tumor-like lesions clinically, right? So this is why we have incorporated some of these things, because the mass-like effect, the tumor-like effect that is seen clinically can mimic a tumor. And so we did want to include some of these to allow people to be able to recognize them. So, thyroglossal duct cyst, there's nothing magical about it. It does have a very characteristic appearance on imaging. You can see the same thing as a, nodule above the hyoid in this particular case of a male patient. And then, of course, the histology with the classical imaging findings, where you have both a cyst, usually lined by respiratory or squamous epithelium, thyroid parenchyma in the background, and usually very closely associated with the hyoid bone. And in fact, a cyst trunk procedure is what is performed in order to have the hyoid removed with it. Otherwise, there's an increase in recurrence. Dyshormonogenetic goiter was included as well. This is a abnormality of genetic derived basis, where just you do not have correct thyroid hormone production, and therefore you get into a goiter formation. Most patients actually usually present 20s to 40s. It isn't something that is seen so often in the early age, and so it is something important to think about. One of the diagnostic features for this is having a very profound, weird cytologic pleomorphism in the follicular epithelial cells, but only in the stromal component. So in other words, only here in the background rather than in the nodules. When you look at the nodules of lesion, you will notice that there is no pleomorphism in them. So it's an interesting histologic presentation of this kind of odd pleomorphism in the follicular cells, but only in the interdigitating or septal spaces rather than in the nodule. Then you get into the follicular cell-derived neoplasms. Of course, here again, we introduce the thyroid follicular nodular disease or multinodular hyperplasia. These two terms can be used interchangeably. Adenomatoid nodules may have been what was utilized previously. We didn't want to have people use the term goiter, since that's more of a clinical term. And so that particular term was eschewed. And as you know, it's just, proliferation of thyroid epithelial cells without any sort of invasive growth and obviously lacking features that are related to papillary carcinoma. So all of us well recognize the diagnostic category of nodular follicular disease or multinodular hyperplasia. And here is just a single slide because, I don't need to belabor that particular point. Then we added in a specific type of follicular adenoma. This is the one with papillary architecture. And the reason why this is included is, there's obviously no features of papillary carcinoma, but quite commonly it is associated with autonomous function, where the patients will actually have symptoms of hyperthyroidism. So the analogy of this particular lesion with the clinical correlation is one that we felt was significant enough that we should include it as a separate lesion, especially since the papillary architecture quite frequently can be misconstrued to represent the features seen in papillary carcinoma. So here is an example. You can see that there are papillary structures here, multiple papillary structures present over here, and you'll notice that there's kind of an absence of colloid. So here there is colloid present in this follicular space, and yet it is absent over here. And here's another example where you can see these very, very elongated papillary structures. And in fact, one of the things that is quite characteristic is that there will be follicles present within the papillary structure itself. And this is not a feature you usually see in papillary carcinoma. Papillary carcinoma tends to be an arborizing, complex papillary structure. This is a very simple edematous structure, and yet here you do have these follicles that form actually within the space. So the complexity here is that it's a interpapillary structure follicle, and that's one of the tip-offs to the diagnosis. So the follicular cell-derived neoplasm category, continuing on now with the low-risk lesions, you will notice that non-invasive follicular thyroid neoplasm with papillary-like nuclear features, or NIFT-P, is the lower end with the thyroid tumors of uncertain malignant potential, and then, of course, hyalinizing trabecular tumor. As you know, this particular tumor has gone through some evolution recently as well, and I'll discuss that here in a moment. So, NIFT-P was included in the previous edition. Nothing new or specific about it other than potentially adding in that you can have microscopic tumors, in other words, those that are less than 1 centimeter, macroscopic tumors, those that are greater than 4 centimeters. And the molecular classification obviously has expanded ever so slightly as well, because as these lesions have been studied more, the number of different mutation, fusion, partner things that can be seen in it are obviously increased. But, histologically, it's still the papillary nuclear features in a tumor that is of a follicular pattern. And I'm going to say exclusively, occasionally you may have isolated papillary structures, which was one of the modifications done immediately after NIFT-P came out. Now, I'm incorporating this particular tumor, not because I believe it myself, and there was quite a bit of discussion about it at the meeting, but kind of in Europe, there is a very strong utilization of thyroid tumor of uncertain malignant potential. I can tell you that in the United States, if you use this particular term, you're absolutely going to get a call from your clinician who's like, what does that mean and what am I supposed to do with it? And so I tend not to use it myself because I don't find it to be valuable clinically. But in essence, it's for a lesion that doesn't fit into classical malignant features. You have something like this. Well, is that starting to be capsular invasion? Is this starting to be capsular invasion? Well, here is the capsule. Is this more than 50% through? I think probably it is, but it isn't quite enough. Could this have been a place of a previous fine needle aspiration and you aren't sure? Here's another area where you can see, this nodule of tumor has expanded immediately below an intact endothelium. So it isn't actually vascular invasion or lymphatic invasion, but, it's kind of worrisome for that. And you've done levels and deepers and you're kind of uncertain. And this is where, the uncertain malignant potential comes into play. As I said, again, this is something used primarily in Europe rather than other areas of the globe, but it is still incorporated in this edition of the book. I have my doubts that it is going to remain in the next edition, given the chatter around the group table at the time. But, the WHO is a very specific and staid organization where you don't want to just change something to change something. You need to have good, strong evidence in order to be able to do so and understand that that evidence, once it's present, should then be acted upon. So at this particular time, there is still some use for the diagnostic category. Now, having said that, I do want to mention that, as we all know, fine needle aspiration changes can definitely be seen in any of the thyroid lesions. I'm happy to be incorporating them here with this uncertain malignant potential, because many times that is part of the story, where you have something like this that is a very rich vascular proliferation, giant cells are seen, hemorrhage and so forth, but this is still the site of a previous fine needle aspiration. I think here you can see a really nice area where there is a capsule going along here, truncated, a capsule going along here, and you can even see that a portion of it has been dislodged or displaced, and a very nice vascular proliferation, histiocytes, inflammatory cells, kind of an organizing thrombus appearance in the previous fine needle. So I think when we do anything with thyroid pathology, it is imperative that you know that the person had a previous aspiration. I must say, I don't always care what the diagnosis was. In other words, it's a screening modality. It's excellent, and you get very good results with it, but also recognize that, being able to tell follicular nodular disease from a follicular adenoma, from a follicular carcinoma on fine needle without any sort of other ancillary testing is not always possible. And therefore, we recognize that it screens you into a particular group, and recognize that the fine needle aspiration changes can really be quite remarkable when the gland has been resected. Now, highlightizing trabecular adenoma, this is a very nice example. This is of an adenoma rather than of a tumor. As you know, the term tumor is used with the notion that potentially are there malignant cases. As you know, this particular tumor is now recognized by the PAX8 and GLIS either 1 or 3 fusion partner. And this particular translocation is very well identified, and in fact, so far has only been seen in this particular tumor. So many of the molecular testing companies have now added this in order to be able to say, when you have a fine needle, that this is potentially the diagnostic entity. It has nuclear features of papillary carcinoma in many instances. You will notice that there are quite a few intranuclear cytoplasmic inclusions illustrated here. Calcifications can be seen as well, sometimes even like samoma bodies. These very characteristic yellow cytoplasmic bodies are actually just abnormal lysozymes in the cytoplasm, but they do have a presentation in this tumor much more frequently than anything else. They're not exclusive to this, but they definitely are much more common in this particular tumor. And then, as you know, there are some immunohistochemical findings, obviously TTF1 being positive because it is of thyroid follicular derivation, same thing with thyroglobulin, and then depending upon which clone you use, PAX8 should also be positive for this tumor. One of the findings initially was that the MIB1 antibody specifically, when performed at room temperature, gave a very characteristic membranous staining rather than our usual nuclear reaction that we look for when we're doing a mitotic index. So many times, though, I will have people send me in a case and say, it is not a membranous staining with Ki67, so it cannot be hyalinizing trabecular adenoma. And then it turns out, that they are not using the correct clone, nor are they using it at room temperature. It's usually had some sort of modification, and it's being done at 37 degrees or something else, and therefore the stain is never going to work. So I'm including this really for an historical perspective, just so if you are looking for this particular finding, it needs to be done in the context of the correct setting. Then moving into the malignant follicular cell lesions, follicular carcinoma didn't really change as a diagnostic entity and category, but the invasive encapsulated follicular variant of papillary certainly did. This is when you have a very well-defined and encapsulated tumor that is follicular in architecture and yet shows invasive growth. Then it's either capsular or vascular invasion. And so here you will notice an example. This is a well encapsulated tumor. I think you can tell from this that it has a really thick fibrous connective tissue capsule. This is one of the tip-offs to anything in thyroid. Whenever I have a lesion in the thyroid gland and it has a exceptionally thick capsule, I'm always worried about tumor malignancy. And the reason for that is the host response to it is exaggerated as a malignancy is in place. And so whenever I see a thick capsule, I'm always worried about evidence of invasion. You do need to have smooth muscle-walled vessels present in the fibrous connective tissue in order to be able to confirm as well that you're dealing with a true capsule. And then, of course, the nuclear features of papillary carcinoma in the encapsulated but invasive follicular variant are very characteristic. So for papillary carcinoma, the major change here is that it is no longer supposed to be called variant. It is only supposed to be called subtype. I will say, though, that for a discipline that has used things like diffuse sclerosing variant, Warthin-like variant, oncocytic variant, all of those variant names are very well inculcated in our literature. And to suddenly change variant is only going to be utilized when you're dealing with a molecular base for a disease, and you should use subtype when it is anything else. I think is going to take more than just one edition of the WHO book in order to be able to incorporate. Well, the thing that's interesting about papillary carcinoma in this edition is the removal of cribriform morula variant and also microcarcinoma. So we all recognize microscopic papillary thyroid carcinoma as any tumor that is less than or equal to 1 centimeter. And in this case, they just are no longer going to be diagnosed as microscopic. You can still classify them that way with the size criteria given, but you should classify it based on the histology. So in this case, it would have been a classical papillary carcinoma, and then microscopic given the overall tumor size. Oncocytic follicular carcinoma, also no real change in that, but just adding now oncocytic preferentially to Hürthl cell. As you know, the cells have abundant oncocytic eosinophilic cytoplasm. It's kind of opacified in its appearance. And of course, this is related to abnormal mitochondrial DNA that shows mutations, and therefore you have lots and lots of these abnormal mitochondria that do give it that oncocytic quality histologically. The next lesion that is really of most significance, and I'm actually going to spend about 10 minutes on this topic just because it is the newest thing in the book and probably one of the most significant as far as how the management of this is done, and that is the follicular-derived carcinoma category. So these are follicular cell-derived lesions, but that they are high-grade, rather than being well-differentiated as you have for the rest of the tumors, or completely undifferentiated as you have for anaplastic thyroid carcinoma. So this is an intermediate tumor category. I do know that people had already posted some questions online prior to the beginning of the conference, and so whoever it was that posted the question, I'm definitely presenting that answer right now, so I hope that you're able to pay some attention to this. So the follicular cell-derived carcinoma high-grade category is really a neoplasm that has high-grade features, defined either by mitotic activity or tumor necrosis and lacking anaplastic histology. So the lacking of anaplastic histology is very significant because if you have that, obviously you've moved into anaplastic or undifferentiated carcinoma. And then the definitions of the other two having mitotic index and or tumor necrosis, along with other features that allow for the separation, at least at this particular time. So poorly differentiated thyroid carcinoma has a either solid trabecular or insular architecture and is malignant by the presence of invasive properties. So it may have capsular and or lymphovascular invasion present, where it's either lymphatic or vascular distribution, an absence of conventional papillary carcinoma nuclear features, and then at least one of the following, and you'll notice here, mitotic count of 3 or more, tumor necrosis, and convoluted nuclei. So it's any one of those features combined with the growth pattern and absence of papillary nuclear features. Now, this is in contrast to the high-grade differentiated follicular carcinoma category. And in this particular case, it's the presence of either more than 5 mitoses per 2 square millimeters or the presence of tumor necrosis. Now, having done some research in this area myself, I can tell you that the tumor necrosis is a much more reliable histologic feature than is the mitotic index. So in other words, I have had and seen many cases where the tumor necrosis is present and the mitotic index is somewhere between 2 and 4 rather than reaching the threshold of 5. So if you're going to spend time on high power looking for these particular features, while it is important to look for mitotic figures, I would highly recommend the tumor necrosis be evaluated specifically in this case. It often will retain whatever the underlying cytology and architecture is of the underlying well-differentiated tumor type, even though it obviously now has tumor necrosis or mitotic figures. And I'll show a few things about this now. So again, you do have this separation, the poorly differentiated carcinoma category, and this is based on the Turin criteria. So, you know, it's infiltrative, right? So here I'm just showing infiltration out into skeletal muscle. If that skeletal muscle is seen macroscopically or documented by the surgeon, or alternatively, if you see evidence macroscopically on imaging, you're going to move it into the T3B category. However, if you only see skeletal muscle involvement histologically, and it was not described grossly and not recognized by the surgeon or seen by imaging, it's still a PT3A category. So this is something where there is a change with the AJCC and UICC 8th editions that is still in place at this particular time. So the poorly differentiated carcinoma category, first let me just focus on the invasion. So I think all of you can see that there are multiple nodules of tumor invasion well beyond the main mass here. You can see these multiple nodules of tumor that have expanded out. In fact, the one in the center is involving a smooth muscle-walled vessel. Here you can see again a smooth muscle-walled vessel filled with tumor and associated with fibrin, indicating that there has been vascular invasion. Another example here, not a smooth muscle-walled vessel, but still a tumor nodule that is way beyond the contour of the rest of the tumor. Now, we still kept that particular criteria for having evidence of vascular or lymphatic involvement, and that is the presence of fibrin, indicating that you do have legitimate destruction of the endothelial cell that has started the fibrinogen cascade, and therefore fibrin has been produced, proving that you do have endothelium involved. Let me just say that the endocrine organs as a whole have a discontinuous endothelium. It's often quite fenestrated. If one thinks of the fight or flight reaction, if you see a snake in the bath, you are already running before you have really thought about it. And the reason for this is that hormone is in the vasculature in less than a second. So you cannot have hormones in a vascular space that quickly if it doesn't have a fenestrated or discontinuous endothelium. So when I'm evaluating this in a tumor, the notion of a discontinuous endothelium is already innate to the tumor. So if I'm trying to say, well, there's loss of the endothelium, that's kind of really tough to interpret no matter what you do. And of course, if you're using a nuclear stain, this does nothing at all. So things like Fly1 don't really help you because they outline that there's a vessel there, but it certainly doesn't tell you if the endothelial actual cytoplasm has been involved or not. So this is where we truly feel that the fibrinogen is a much more reliable marker. So here, this is not vascular invasion, right? This is just entrapment. You have a vessel on either side and there's a little bit of tumor, but this is not within a vessel space. Here you will notice a vessel on either side. And this is just entrapment of the tumor. It does not represent actual invasion. I'll show it here on higher power, where you can see that the endothelium is on the outside and the tumor has just grown up adjacent to it, but is not being identified within the vascular space. So this is not evidence of vascular invasion at all, in my opinion. However, here are multiple vessels that are involved, and they actually tend to be seen along the septa of the thyroid gland. Here you will notice a nice vessel. It has a smooth muscle wall. It even has, well-developed fibrin associated with it as the tumor has invaded into that space. So the poorly differentiated category here, I think all of you can tell, creates a very interesting retraction artifact, and that's what's highlighted in this image, where the tumor cells kind of draw back from the adjacent surrounding tissue. Of course, this can sometimes simulate vascular invasion when you think about seeing the same thing in breast lesion or something like that, but it is not really an infiltrate, a vascular retraction. It's just pulling away from the adjacent stroma. So this is kind of a trabecular and insular architecture, another area here showing an insular architectural pattern. And this is one of the ones that is quite prominent, although many times you will have a solid architecture as you see here. And so it is a mixture of this trabecular, insular, and solid pattern within one single tumor, and recognizing it can be quite variable from one tumor to another. Quite often it has very limited colloid, so you can see that there are little globules of colloid present in the center of each of these almost microfollicles. It is obviously other areas may not have the exact same feature. This, I think, is a more follicular architectured pattern to the tumor, but just recognize that there can be a wide variety of different patterns seen within these tumors. Now, many times they will have increased mitotic activity. Here I'm just highlighting 4 different mitoses in a single high-power field. So clearly the idea of having 3 per 2 square millimeters for the poorly differentiated category is going to be met without any problem in this particular tumor. Similarly, tumor necrosis, as you can see here, it is a genuine coagulative necrosis where the nuclear outlines and the cell outlines can still be seen. A nice example here where you can see that there is evidence of necrosis in a central fibrous core. Sometimes the evidence of necrosis is a bit more subtle. You can see the 2 areas here where the nuclei seem to have just dropped out, and yet they are remained as an outline of the cell. And sometimes this is the only feature you see. So you do need to be on a higher power in order to be able to recognize it, versus something like this, where I think you can see that there is well-developed tumor necrosis. One of the features with thyroglobulin and the poorly differentiated carcinoma category is it does tend to give you this very globular appearance. And so you'll notice all of these little dots of positive thyroglobulin and it is quite characteristic for the poorly differentiated carcinoma category. So let's now go to the high-grade differentiated as an alternative. And here you can see the architectural pattern obviously is whatever the underlying tumor is, right? So if it's a papillary carcinoma, it's going to be papillary. If it's follicular pattern, whether it's a follicular subtype of papillary or a follicular carcinoma, it should still be that way. And of course, you can also have a solid appearance. And then the nuclear features, again, are going to be whatever the underlying tumor is. And it is only based on either mitotic count or tumor necrosis. Of course, again, highlighting that no anaplastic features can be seen in this particular tumor. So here's a nice example of multiple nodules of capsule invasion where it's really extended out beyond the main tumor and out into the adjacent parenchyma. Another example of capsular invasion where you can see that the capsule has been completely transected with this mushroom-shaped evidence of invasion. Well-developed vascular invasion. I think if you go and look at these, you will see that there is neoplastic cells present in the lumen, and then, of course, having evidence of fibrin production immediately adjacent to it. The erythrocytes and blood may be present, but it's more recognition of the fibrin that is more clinically significant. And then, of course, you can see smooth muscle-walled vessels with tumor present within them as well. So vascular invasion or lymphatic invasion is usually easily identified. Now, this is an underlying papillary thyroid carcinoma, and I'm using this just to highlight multiple nodules of tumor, but also showing you the central tumor necrosis, evidence of kind of a solid pattern in this papillary thyroid carcinoma, because again, papillary nuclear features can be seen when you go to high power. Another example here of papillary carcinoma with well-developed tumor necrosis, and I'm highlighting various types of tumor necrosis because then, again, the moment you have tumor necrosis, you're going to leave whatever the underlying well-differentiated tumor category is and place it into one of these high-grade categories. Sometimes the nuclear features are fantastic, but you can tell that they go immediately into an area that is a little bit more oncocytic or oxophilic in appearance, and yet still having the same nuclear features. Tumor comedonecrosis, again, is quite characteristic for this tumor and needs to be identified within it. Areas of more solid pattern can be seen as well. Nice area here showing the area of tumor necrosis. A transition between different patterns is often quite common with the papillary carcinoma, much more classical and characteristic on the left-hand side, whereas the right-hand side is almost giving you more of an insular to solid pattern. I'm doing this specifically to say that the insular pattern is not unique only to the poorly differentiated carcinoma category, and insular architecture can sometimes be seen in a papillary carcinoma subtype, and yet recognize that when you have tumor necrosis or increased mitotic figures, it moves it into the high-grade differentiated category. So very characteristic papillary nuclear features with tumor necrosis, well-developed tumor necrosis here, again, out on the outer aspect, and I won't sort of belabor the point here, just highlighting that here is an oncocytic follicular carcinoma and yet also having genuine tumor necrosis, even though it is an underlying oncocytic tumor. The oncocytic tumors, as you know, can develop degeneration, and so it's important for any of the oncocytic lesions to make certain that you're dealing with genuine tumor necrosis rather than just an oncocytic degeneration due to lack of oxygen or disruption of the vascular supply. So again, here is a nice example of a oncocytic follicular carcinoma, and yet here you can see both increased mitotic activity as well as evidence of tumor necrosis. Well-developed tumor necrosis here where the outlines are identified, and that's the most important and significant finding. Now, one of the tip-offs to me is you can see this is an area of what I would refer to as apoptotic change. So you can tell that the nuclei have died, but they're still present, the nuclei are still seen, and the cytoplasm has now congealed around it, so it gives you this very dense eosinophilic appearance. And when I see this, this is not evidence for me of tumor necrosis, but I am going to spend a lot of time looking for where the tumor necrosis actually is, because to me, this is the precursor to tumor necrosis. And if you have this, especially in such abundance, you're going to have tumor necrosis somewhere else in that tumor. Sometimes just seeing abundant histiocytes, as you can see here, these are histiocytes that are eating or taking up destroyed follicular cells. Again, when I see a lot of histiocytes like this in the center of a tumor, I am very concerned that tumor necrosis is going to be present somewhere else in the lesion and therefore should be evaluated. Now, someone had asked about the various molecular alterations for either poorly differentiated carcinoma or the high-grade differentiated follicular carcinoma category. And you will notice, here is just a selection of some of the most common. But I think in the poorly differentiated, you will notice that RAS and TERT are the most frequently present in this tumor. They certainly can have others, but they definitely have RAS and TERT most frequently. Whereas if you look at the high-grade differentiated category, BRAF is much more commonly identified. And this is because it is a papillary thyroid carcinoma first. It undergoes either tumor necrosis or increased mitotic activity, whether that's through a TERT promoter mutation or not, certainly can be accounting for it. And this is why you have an increase in TERT promoter mutations as well. So anyway, it is a slight overlap, as you can see, with TERT, but just recognize that BRAF, when it is present, is much more frequently identified in the high-grade differentiated category. So, we always look at historical things, and this is a Caravaggio painting from 1607, and you may say, well, why are you showing that? It's to show that goiter has been around forever, right? I mean, if you look at this guy in the bottom, and let's look at him on high power, this is a massive goiter, and this is really what you would expect to see clinically in an anaplastic thyroid carcinoma. And so let's talk about anaplastic just for a moment. The major change here is squamous cell carcinoma is no longer included. It is considered to be a subtype of anaplastic carcinoma. So if you're talking about anaplastic, now you would also include a subtype of squamous cell carcinoma rather than having squamous cell carcinoma as a separate entity. When you look at it, it has remarkable anaplasia and pleomorphism, tumor necrosis, increased mitotic activity, usually lacking thyroglobulin in the neoplastic cells, also lacking TTF1 in the neoplastic cells, but still maintaining PAX8 immunoreactivity as one of the features that can be used, along with epithelial markers like the pan-cytokeratin. Let's go on now to the salivary gland neoplasm group. Mucoepidermoid and secretory carcinoma, these are tumors that are recognized histologically as mimics of what you see in major salivary glands. When you go on to high power, the secretory nature is present, although when you're talking about thyroid, the entire thyroid is secretory, and therefore all tumors in the thyroid are secretory because they're secreting thyroglobulin. But for this particular tumor entity, just recognize that mucoepidermoid carcinoma here actually has mucin production highlighted with mucicarmin immunoreactivity, and will show the same MAML2 translocation that you have in anatomic equivalence in the salivary gland. Then secretory carcinoma as well has very, very similar features to papillary thyroid carcinoma, with the nuclear features often a mimic, but here you do have a secretory type product. But in this particular case, the S100 is going to be remarkably positive, while TTF1 is negative. So you will notice that in the neoplastic cells, there is no TTF1 reactivity. I included some of the surrounding parenchyma just as an internal control, but you will notice that it is now completely negative. And of course, for the most part, the canonical ETV6 fusion is usually present, although there can be some other fusion seen in this particular tumor category as well. For the uncertain category, sclerosing mucoepidermoid carcinoma, this is still kind of a uncertain tumor category because it does not have either MAML2 or BRAF mutations. It has a very heavy, remarkable sclerosis, sprinkling of eosinophils throughout, and then, of course, the same histologic appearance as mucoepidermoid carcinoma, with mucin production being present and highlighted with the mucicarmin. So this still needs additional work. I'm hoping that in the 6th edition, someone will have come up with a little more about this particular tumor. As you know, they are very, very uncommon. Now, cribriform morula used to be a subtype of papillary carcinoma, although we all recognize that it really, wasn't, because it had a very different beta-catenin pathway and association with familial adenomatous polyposis, although certainly solitary cases can be identified as well. And it is a very characteristic sort of cribriform or morula with squamous area identification, and those morels are actually quite uniquely reactive with CDX2 and CD5, which is a little bit different than what you would expect to see in thyroid lesions, with, of course, no thyroglobulin or PAX8 immunoreactivity, even though it does have TTF1. So we recognize it is a unique tumor entity now, and cribriform morula thyroid carcinoma is a separate entity. So here you can see a bit of papillary architecture as well as a cribriform pattern, much stronger cribriform appearance in this particular image with heavy sclerosis separating between nodules of tumor. Again, a very nice cribriform architecture, a little bit of a squamous morial present here, a much better squamous morial, and finally a really fantastic squamous morial. They're not always that easy to identify, but if you're bombing around on 4 or 10x, you should be able to identify them. And again, uniquely, they do have interesting immunohistochemistry. So for the most part, beta-catenin shows a strong and nuclear and cytoplasmic immunoreactivity, referencing the CTNNB1 mutations that are seen in these tumors. But you will notice TTF1 does not mark the squamous morials at all. They usually have a lack of reactivity. And here you can see reactivity with CDX2 and with CK5. Sometimes even CD5. So just recognize that those squamous morials are in fact quite different immunohistochemically as well as being histologically identified. So we've always had thymic-related tumors in the thyroid gland, thymoma as an entire family, because any one of the thymoma types can develop, whether it is the A or B or AB or whatever the other groups are. They certainly can all be seen within the thyroid gland, as well as two of the carcinoma categories with spindle and epithelial tumor with thymus-like elements, as well as carcinoma with thymus-like elements. So again, thymoma is going to be no different than anywhere else in the body, with the classification scheme using that has been provided in the thoracic book. And then here is an example of a settle with a spindle and epithelial lesion. You can see the nice spindle cells here, and then the epithelioid component, often with this very well-developed connective tissue in the background. Carcel, this is thymic carcinomas just in general. We still use carcel as an abbreviation for it, but recognize it is thymic carcinoma just in a different anatomic site. And in fact, many times when you think about thyroid and its embryological development in very close association with the thymus, and sometimes, you'll have thymic tissue immediately adjacent to the thyroid. So whether it's actually derived intrathyroidally or is perithyroidal and invading into the gland is, of course, sometimes not easy to separate. The thymic tumors, of course, cover a wide variety. There's a table in the book like this to help you with the separation between the various tumor categories that you may see within the neck space and specifically around the thyroid gland. So thyroblastoma was included specifically because it is an embryonal high-grade tumor that is associated with Dicer1 for the most part. And in this particular case, it just is very primitive in its overall architecture, with very primitive appearance of both cartilaginous and mesenchymal elements, as well as the epithelial elements. Those epithelial elements are usually related to thyroid derivation of an early embryologic nature, and of course can take on a very anaplastic overall appearance. They will be positive with SAL4, which is one of the findings that is quite unique to this tumor, while recognizing that the various elements within it, if you think about the previous description of these lesions as being part of a teratoma or a malignant teratoma is where most of these were derived from. TTF1 and even Desmond, some of the other mesenchymal markers, will be positive in these primitive neoplastic cells. So let's transition now just to the mesenchymal tumors. I'm not going to go over all of them clearly, but what I'm doing here is just highlighting that each of these tumors can develop really in any one of the sites. So if I talk about schwannoma, recognize that you can have a schwannoma in the adrenal gland, you can have one in the pancreas, you can have one in the thyroid, pituitary, or even parathyroid, and just know that those tumors are going to be present there. Here is a nice example of a solitary fibrous tumor as a nodule within the thyroid, giving you this very nice, short, irregular fascicles of blunt-ended neoplastic cells immediately associated with and involving the thyroid follicular epithelial cells. And as you know, these are very nicely and strongly positive with STAT6. So I'm not going to go over any of the other soft tissue-related lesions. Just know that this is an example of one of them within one of the organs. And of course, we're talking about thyroid here, so that's why I selected thyroid. Same thing with the hematolymphoid lesions. The IgG4-related disease was added in here, even though it is not considered a tumor. It is, I should say, a neoplasm. It is considered a tumor in the sense that it creates a nodule or a mass lesion, and therefore this is why it needs to be recognized. With both the various lymphoma categories, primarily extranodal marginal zone and diffuse B cell, certainly isolated case reports are present of other neoplastic lesions in the hematolymphoid area, but rather than cataloging every single one, these were the major ones that have been incorporated. So, I'm just going to show an example of Langerhans cell histiocytosis in the thyroid, very classic and characteristic appearance with the, convoluted nuclei and a strong association with eosinophils in most of these lesions. The germ cell tumors were separated into two different categories, those that involved endocrine organs primarily, and then teratomas that showed endocrine differentiation. So I think if you recognize, that you can have a teratoma in the thyroid or a teratoma in the adrenal, we all recognize that. However, it's the teratomas in other locations with endocrine differentiation that I think is a little bit more interesting. And so struma ovariae is a very nice example of those, where it is an ovarian-based tumor as a teratoma in which thyroid is one of the most voluminous as far as within the lesion. You can also have malignancies that are neuroendocrine type tumors, and then the term is different for that particular category within either the ovary or testis, or sometimes even in the mediastinum. So recognize that you can have teratomas elsewhere in the body and still show evidence of either neuroendocrine or just endocrine differentiation. The metastases were separated out into kind of three major groups to each of the major organs: pituitary, thyroid, and adrenal. I mean, there isn't really a strong metastasis to parathyroid. It does happen, but it isn't a major category. And of course, because pancreas is both an endocrine as well as an exocrine organ, it was in the exocrine section of the GI book that particular topic was covered, so we didn't repeat it here. So a nice example of metastatic renal cell carcinoma to the thyroid, another here of metastatic lung adenocarcinoma. As you know, the lung adenocarcinomas are TTF1 reactive, so you definitely cannot use TTF1. And I will also say, if you use napsin, napsin is strongly positive when you're talking about tumors that develop within the tall cell subtype. So napsin and TTF1 cannot be used at all to make this separation. Thyroglobulin, however, is going to be the marker that is helpful in this setting. And then finally, we get to the tumor genetic syndromes. In this particular case, they are primarily the 15 different entities that have a major endocrine presentation as their clinical finding. We all recognize that many tumors can develop. They can be seen in the thyroid, adrenal, pancreas, pituitary, etc. But this is really when the major manifestation of the tumor is within endocrine organs. So rather than go over all of them, I'm just going to highlight one just as an example. So the hyperparathyroidism jaw tumor syndrome, as you know, this is defined specifically by an autosomal dominant pattern of inheritance, and then with pathogenic germline sequences or variants and deletions in CDC73. And then kind of the characteristic findings that you see with it, with parathyroid adenomas or carcinoma, and then fibro-osseous jaw lesions. So in this case, that one sentence that is the highlight of every single tumor syndrome. It's the first thing as part of the definition for every one of them. And it is supposed to be what the inheritance pattern is, what the pathogenic germline sequence is, and then what are the major manifestations that you need to look for. So I think this is a very well-developed, standardized way of coming up with a definition where each of those particular four elements need to be included in every one of them. There was also a major effort to have the MIM numbers included, so that if you have that in, you're able to get a very easy link through to the MIM section where they go over all of what the various features and genetic abnormalities may be for that lesion. So, in this case, it's a parafibromin deficient tumor. I'm just going to say that, there's usually a much more common perinuclear cytoplasmic clearing with nuclear enlargement. So you can actually look at it histologically. Here you can see an example of a parathyroid adenoma. You look at it on higher power and it's kind of sheet-like. You go into much higher power and I think you can tell that it has this very, very prominent profound pleomorphism isolated in some of the nuclei, with this clearing around the cytoplasm accentuating the cell borders or membranes. So when I look at this, I'm much more likely to think, this is going to be some sort of parafibromin deficient tumor category. And in fact, when you do parafibromin, because it is constitutively expressed, you would be able to see that it is lacking in the nuclei here. So with that, I get to the end of our presentation. And I will tell you, we always have fun with these meetings. I know everyone says they're contentious, and you may, fight like the dickens for your particular diagnostic category at the time, but just recognize that we do still tend to have fun with the meeting and be able to enjoy it. So in this particular case, you'll notice I put on a halo around my head up here with thunder and lightning to say we have finally reached the end of this meeting. And I'm just going to highlight down at the bottom, it says it's 2 a.m., right? This is the time. So these meetings are global, which means everyone is coming in from a different time frame. And because I'm on the East Coast in California, it was always terrible for me because the meetings would start at 11 at night and go until the following day at 1 o'clock. So anyway, it was a very enjoyable experience, and we certainly had a load of fun coming up with a classification that we hope will have a global impact and allow people uniformly to apply the same criteria so that we can have fantastic research to aid in patient management long term. So with that, I'm happy to take any questions that you may have. I'm going to look in the chat, so give me a second. And I'm not even sure if my video is showing or not because I can't see if it's reflected. Okay.
Yeah, no, thank you. Thank you, Dr. Thompson. I have put the questions for you in the chat box. I can read it for you and then.
It's fine. I can do, I'll do the first one about prognostic significance in LVI. So obviously the question really is, if you have invasion into a vessel, does the actual number of vessels really make a qualitative difference? Well, yes. The reason for this is if you think about the widely infiltrative tumor category, it's called widely infiltrative because there is a lot of lymphovascular and capsular invasion, and those tumors do have a worse patient prognosis. However, I would like to just clarify that if you have genuine vascular or lymphatic invasion where you have fibrin identified next to the tumor, the potential for that particular tumor to develop metastatic disease is there. Whether it is involving 1 vessel, 10 vessels, or 20 vessels, it still is the potential to metastasize. So recognizing that particular component, I think, is the most important. You can then try and count vessels. But remember, as you look at the surrounding area of a capsule, the vessel may penetrate in and out that capsule as you move around it. And so you may say, well, I see 4 areas of penetration, but it may be 4 areas of the same vessel. So there is some difficulty in coming up with an actual legitimate count of the number of lymphatic or vascular channels involved. And so for me, it is much more imperative to look at it in the notion of, is it widely infiltrative or not? And if it is, can you come up with a quantification that is going to be helpful? I did this with a series. And in fact, if you have more than 20 foci of either lymphatic, vascular, or capsular invasion, so it doesn't really matter which one of those particular elements are present, if there are more than 20 foci, the people have a worse prognosis. So yes, there is clearly something about the number of vessels or number of foci of invasion, but I think once it gets to a very high number, there is not going to be the same necessity to classify each of those particular lesions. So the next question is a 3.2 centimeter, we're really going to get specific, 3.2 centimeter encapsulated bland follicular patterned lesion has an 8 millimeter nodule within it that is a microfollicular pattern with mitoses of greater than 5 per 2 square millimeters and no necrosis. Would you call it a differentiated high-grade thyroid carcinoma? And the answer is yes. So they are a very small but well-defined subgroup or cohort of cases that have increased mitotic activity not adjacent to a previous biopsy site. So not adjacent to a fine needle or a core needle biopsy site, and you have increased mitotic activity. In those particular cases, we have elected at this point to still call them encapsulated high-grade differentiated follicular cell carcinomas, and recognize that at this particular point, they seem to have a better prognosis than the other group. But we also, when you're talking about coming up with new definitions for lesions, want to be as narrow as possible, because if you are too broad, then you kind of begin to dilute the category. So at this time, even though there may not be evidence of capsular invasion, that high-grade differentiated category, if it meets the criteria of tumor necrosis or increased mitotic activity, should be included in it, and with a note indicating that there is no capsular invasion, and probably they are going to have a good prognosis, but still that is something that is not known at this juncture. I mean, I have 4 cases that fit into that particular group in my own cohort right now. So far, none of them have developed metastatic disease or tumor recurrence, but they have follow-up of less than 4 years. So as you know, with anything in the thyroid gland, we talk about 10 and 20-year survivals of 98%. So if you're talking about a 98% survival of 20 years for papillary thyroid carcinoma, you need to follow these lesions for a longer time than just the short interval of 4 or 5 years. Let me look at the next question. They're all so long, my goodness. So papillary-like and papillary-type nuclear features, sometimes difficult. Which nuclear feature is actually present? So I do think that the papillary nuclear features, when you're talking about a follicular patterned tumor, the most reproducible for me is remarkably increased nuclear size, and that is therefore going to give you an increased nuclear to cytoplasmic ratio. And the second is nuclear contour irregularities. So the grooves, folds, contour irregularities, no matter the fixation, you can even see them on frozen section related material. Those two features are the ones that are the most likely to be reproduced. So the nuclear chromatin quality distribution is not as easy to separate. And of course, intranuclear cytoplasmic inclusions for me are not a reproducible criteria for the separation of papillary nuclear-like features. If I think of an oncocytic adenoma, and even an oncocytic carcinoma, the oncocytic cells have so much cytoplasm that they push into the nucleus and give you intranuclear cytoplasmic inclusions, even more so on fine needle aspiration, because you're actually smearing, and as you smear, you're going to induce that intranuclear cytoplasmic inclusion in some of the cells. It's usually a fake inclusion, but they can still be seen. So for me, the most important criteria is nuclear size and contour irregularity. And then the idea of using BRAF to distinguish between the two, absolutely not. Because if it's a follicular patterned tumor, the BRAF should not be positive. I mean, you may have BRAF K601E present, but the BRAF V600E is not going to be positive. And that particular analyte is what is actually being detected by the immunohistochemistry. So if I have a follicular patterned tumor, and I'm trying to decide if it's nuclear features or papillary, BRAF is going to be absolutely useless, and I would not recommend using it at all. Would you consider mushrooming with extension to the nearby thyroid tissue minimally invasive or widely invasive? So I would still consider that within the minimally invasive category, because a mushroom through the capsule, if there isn't a lot of other tissue adjacent to it, may be a larger mushroom than not. What if it's right at the periphery of the thyroid? As you know, there's no thyroid capsule that just goes out into the adjacent soft tissue. So it may extend a little bit further. For me, widely invasive means that there is an extensive number of areas of invasion. This is not related specifically just to the size of the capsular or vascular involvement, but it's the number. So when you have just a huge number of these foci as they project out into the adjacent parenchyma or soft tissue, that's when widely invasive would be utilized. So someone has said, is it crucial to differentiate lymphatic versus blood vessel? Absolutely. So we sometimes will use the term lymphovascular invasion to incorporate both lymphatic and vascular invasion. The only time I really use that particular term is when I'm trying to say there is none. So if I say there's no lymphovascular invasion, I'm conveying to you that there is no lymphatic and there is no vascular invasion. Well, why is there a difference? So if you think about the metastatic profile, if you have a papillary carcinoma, most commonly, they go into the lymphatics and therefore they present in lymph nodes. And from the lymph nodes, they then go into other anatomic sites. Whereas if you think about the follicular patterned tumors, like a follicular carcinoma, or some of the higher grade tumors, they tend to involve vessels rather than lymphatics, and therefore they go to lung, liver, bone much more commonly than they do to lymph nodes. So if you do not make that particular separation, the chance that the people are going to be doing the correct monitoring and follow-up of these patients is going to be a little bit different. So if you only say there's lymphatic invasion, perhaps there's going to be a concentrated effort on what's going on with the adjacent and neck lymph nodes, rather than if you say vascular invasion, trying to come up with what may be going on distantly in the body. So I do feel it is absolutely critical and imperative to make that separation. I do not use immunohistochemistry to try and make that separation, though. I don't use different markers like, D240 or trying to do CD31 or CD34, et cetera, to make that separation for me. I base it on the presence or absence of smooth muscle in the wall. And that's the most reliable feature because you can usually see that. So the question is about BRAF V600E immunohistochemistry in tumors of uncertain malignant potential. Well, the reason I'm going to say it's probably not going to be of value to you is the tumors of uncertain malignant potential are usually follicular patterned lesions where you cannot determine if there is evidence of invasion or not. So a follicular patterned tumor, even if it has nuclear features of papillary carcinoma, is still not going to be BRAF related. So again, if you go to the underarching tumor categories of papillary architecture tumors generally are in the BRAF family, whereas follicular patterned tumors tend to be in the RAS-related family. I mean, there can be other mutations and fusions seen, but just the overarching categories. So if you're talking about BRAF immunohistochemistry, this is really highlighting lesions that are in a papillary architecture rather than in a follicular architecture. So I don't think that the BRAF V600 IHC specifically is going to be of value in the uncertain malignant potential. So the next question is, intratumoral vessel invasion in a follicular carcinoma is not a criteria for diagnosis. Why not? Well, because it is still contained within the tumor and doesn't actually go anywhere. So it needs to be in the capsule or beyond for vascular invasion to actually result in metastasis to a distant location. So this is really based specifically on biologic behavior, and therefore anything that is within the center part of the tumor does not count. It's the same with adrenal gland, by the way. If you have a tumor involved vessel in the center of a pheochromocytoma or adrenal cortical lesion, it still does not qualify as invasion. It needs to be at the capsule or junction with the surrounding tissues. The next question is there any chance of anaplastic features in a high-grade follicular-derived neoplasm, and how to approach that? You cannot have anaplastic features. So if you have anaplastic features, even if they are focal, I would still not put it into that particular category. I would move it into the anaplastic or undifferentiated category. Now, they do need to be very well-developed anaplastic features, not just degenerative change. If I can use either symplastic leiomyoma of the uterus or perhaps ancient change in schwannoma, if I can use soft tissue-related lesions. There you have isolated and fairly profound pleomorphism, and yet it isn't universal, and therefore it is not seen throughout the whole lesion, so I wouldn't count it. But you're talking about a true evidence of anaplasia in a thyroid neoplasm. When you think about anaplastic thyroid carcinoma, it's an arc of development, right? So you start off with a well-differentiated tumor. In general, you go through a high-grade differentiated tumor, and then you get to anaplastic. So quite frequently in anaplastic thyroid carcinoma, if you look around hard enough, you will find the underlying tumor category, and most of them are papillary thyroid carcinoma. So you can still find underlying papillary thyroid carcinoma features somewhere in the tumor. And therefore, they start somewhere, right? So if they're starting somewhere and you have those anaplastic features, it's probably wise to be able to use them if you have them and put it into a higher grade category. So the next question, I am sure, should probably be my last. I don't know how long we're supposed to go on for. But the question is, do you use CK19, galectin-3, or HBME1 to differentiate benign mimics? No. Now, I have seen approximately, someone had done a calculation for me on my database, and I think there were 39,000 thyroids over the last 28 years. So I have never performed any of those immunohistochemistries in order to be able to distinguish between follicular pattern tumors in the thyroid gland. Now, you may say, well, then why do you have pictures of it? Well, it's because when people send me a consult, they send those immunos too. And so then I do think, obviously they must not help you because you still sent the case for a consult. So I'm being a little bit facetious and funny, but really in a classical papillary thyroid carcinoma, all three of those are going to be positive. But when you're looking at it in a follicular pattern tumor or something else, they are so wishy-washy, they're so focal, they may be super strong, but in like 5% of the cells, so that they are never really a very robust technique for me to be able to interpret. And I am definitely a classical H&E trained pathologist. And so for me, I get much more information from the H&E than I do from trying to use immunohistochemistry, because those particular findings just don't tend to be as helpful in my view. I'll end with this, though, because it is kind of an important question. If metastases are present, but lymphatic invasion cannot be found on the sections, how do you report it? So this is the exact same criteria that you would use if you were reporting breast lesions. So quite frequently, I would have a lumpectomy specimen, no evidence of lymphatic invasion in any of the tumor sections I had submitted, and yet obviously the lymph node was positive as a sentinel lymph node with metastatic disease present. So in that particular case, what you're saying is the amount of lymphatic invasion must be so limited, and yet it still has resulted in the presence of metastatic disease. And of course, when you think about lymphatic or vascular invasion, it's an indicator of the potential to develop metastatic disease. Well, if you already have metastatic disease by fact that you have it in a lymph node or in bone or wherever the other anatomic site may be, the risk has already been developed at 100%, and therefore the risk stratification of lymphatic and vascular invasion has already been met. So I would still say that LVI is not present, and yet still document that the metastatic disease puts it into a high-risk category. So with that, I would like to thank you for all of your questions and comments and for joining today. I think people put other comments on the Facebook or other pages, so potentially I could look at those and maybe answer a few more online, depending on how that works out. So thanks very much, and I hope you have a fantastic day.
Yeah, thank you. Thank you so much, Dr. Thompson. This was just a comprehensive overview of the WHO update on thyroid pathology. And as you have seen that there are so many questions, and it was so widely attended, and you would be happy that over 200 viewers joined from all over the world. And in fact, I could count colleagues who joined from 20 different countries, including Sudan, Algeria, Tunisia, Ukraine, Uzbekistan, Nigeria, Nepal, Libya, Mongolia, India, Turkey, to name a few. So,
and in those countries, this is definitely not the normal business hours. So thank you for staying up late or getting up early.
Thanks so much. Thanks all our viewers for your support, and thanks for listening. So follow Pathcast on our Facebook page, subscribe to our YouTube channel, and also we have an Instagram account. You can stay updated and follow that. And also follow our account on X. I have to say X now. So like follow that so that you can stay updated. And our next lecture is coming up on March 12th. So that would be a breast pathology lecture for residents who are preparing for boards, which is coming up soon in US. So hopefully residents will find it useful. And our speaker will be Dr. Kristen Muller from Giesel School of Medicine at Dartmouth. So that's March 12th. Hope to see you at that time. And thank you again, Dr. Thompson. This was amazing. Thanks a lot.
Pleasure. Have a good day.
Bye.